relationships were found. So today I'm going to introduce Amir Khan. He was our sub-I for the last month. He'll be talking on the effect of sarcopenia and body composition on survival in renal cell carcinoma. He has actually had an interesting stay here. This is his fourth sub-I, and for those of you who don't remember, sub-internships, they are challenging and long, and yet he did it with gusto and did a great job. He was very involved in patient care, coming to the OR, maybe from all those sub-Is, was quite knowledgeable and has been a model student overall. A little bit more about him. So he was born in Detroit, but he grew up in Memphis, Tennessee. He went to Dartmouth for undergrad and then came down to Emory for medical school. He's a big language enthusiast, so he's fluent in Urdu, Punjabi, and Spanish. So for that reason, please come here. And he's currently actually obtaining his Spanish medical interpreter certification. He wrestled in high school, and he loves martial arts. He's currently training in boxing. Without further ado, Amir.
Good morning. Thank you for the introduction, Campbell. For those of you that haven't met me, my name is Amir Khan. I'm the visiting student from Emory University. And today I'll be talking about the effect of sarcopenia and body composition on survival in renal cell carcinoma. I have no financial disclosures or conflicts of interest. And so just to give some background, what is sarcopenia? Sarcopenia is defined as a loss of skeletal muscle mass. There's been this increasing focus on sarcopenia and patient-specific tissue segmentation because BMI has been shown not to necessarily be indicative of overall body composition. One of the things I always like to say is that Michael Jordan, at the prime of his career, had a BMI of 28. So that tells you that BMI doesn't really give us the big picture of a patient's overall body composition. You can have a high BMI, but still have very poor musculature, and you can have very low BMI, but still have very robust musculature, and vice versa. So there's been this shift more towards tissue segmentation, which can present a more precise quantification of body composition that can be specific to the patient. So there's been this growing importance, particularly of sarcopenia, as a potential prognostic factor in a variety of settings, including malignancy. So how do we measure sarcopenia? Oftentimes it's measured using a segmentation software. The most common one that you'll see in the literature is called Slice-O-Matic. It's from this company Tomovision in Canada. Basically what you can do on this software is you can segment tissue on axial imaging using either CT or MRI abdomen pelvis. And so what you do is you segment you take an axial imaging DICOM and you get it at lumbar level mid L3. The reason why you isolate this slice at mid L3 is because it's been shown to be reflective of total body composition in the literature. And so once you have that slice at mid L3, you can use Hounsfield unit thresholds to segment skeletal muscle. So the threshold is -29 to +150 Hounsfield units to segment skeletal musculature. And so using those thresholds, you can segment the skeletal musculature to get skeletal muscle area. And so how do we assess sarcopenia? Well, we use the skeletal muscle index, or SMI. Basically, it's sort of an analogous component to BMI, except for skeletal muscle. And so you calculate it using the skeletal muscle area that we obtained at mid L3 in centimeters squared, and you place that over patient height in meters squared. And so that gives you this value of skeletal muscle index. So I love this figure because it really highlights the point I was making earlier. What you can see here is on this top row, you have patients with varying BMIs. So you see a patient with a really high BMI, low BMI, but yet they have identical skeletal muscle index, seen here in red. So what that shows you is that these patients across BMIs, but yet they actually have the same musculature in terms of their skeletal muscle index. However, in this lower row, what you can see is patients with identical BMI. So they all have the same BMI, but look at the variation in their musculature from someone who's sarcopenic here, someone with very robust musculature here. And so that highlights that point that, BMI doesn't necessarily tell us what a patient's body composition specifically is. And so here you can see that there's just so much variability. And so what are the thresholds we use for skeletal muscle index to define sarcopenia? Well, there's different thresholds used in the literature, but the most common threshold uses gender and BMI specific cutoffs. And so what you can see here is that for men, the cutoff you use is 25, a BMI of 25. So for patients with, for men with a BMI under 25, the cutoff is 43, but yet for men with a BMI over 25, the cutoff is 53. For women, the cutoff is the same irrespective of BMI, so the cutoff that we use is 41. This is the most commonly used thresholding we use for sarcopenia in the literature. In addition to SMI, there's other body composition parameters that we can look at. So skeletal muscle density, it's been shown in the literature that the mean attenuation in Hounsfield units of the segmented skeletal muscle, which you can see here in red, that can reflect the density of the skeletal muscle. In that greater Hounsfield units reflects very dense muscle, and muscle with a lower mean attenuation in Hounsfield units reflects poor density muscle. And then you can also look at adipose tissue, starting with intramuscular adipose tissue, which you can sort of see here in the green, visceral adipose tissue, seen here in yellow, and subcutaneous adipose tissue, seen in teal. And if you combine those, you get the total adipose tissue that a person has. And so you have these additional body composition parameters just outside of skeletal muscle index that we can look at. How does this all relate to kidney cancer? Well, there's been some studies looking at sarcopenia and skeletal muscle index and renal cell carcinoma and how it relates to outcomes, specifically survival. There's a study by Sharma et al. Out of Tampa, it's published in Urologic Oncology, that looked at sarcopenia as a predictor of overall survival after cytoreductive nephrectomy for metastatic kidney cancer. This was a retrospective study, looked at the effect of preoperative sarcopenia and how it impacts overall survival after cytoreductive nephrectomy. They had 93 patients with metastatic kidney cancer. Interestingly, they found that BMI was not a significant predictor of overall survival. So again, highlighting that point that BMI is a very mixed picture. We don't really have a clear understanding. But sarcopenia was an independent predictor of overall survival. There's a median overall survival of 7 months for sarcopenic patients versus 23 months for non-sarcopenic patients. So you can see this sort of significant effect of sarcopenia on survival. Another study by Sutka et al. Out of Mayo, it's published in Journal of Urology, that basically looked at the same parameters, but they looked at non-metastatic kidney cancer after radical nephrectomy. In this study, it was a retrospective study looking at preoperative sarcopenia before radical nephrectomy for metastatic kidney cancer. There's over 300 patients with non-metastatic kidney cancer. Again, they found sarcopenia was an independent predictor of increased mortality, cancer-specific mortality and all-cause mortality. And interestingly, aside from that categorical effect, there was also this continuous effect. So increasing skeletal muscle index, the SMI that we were talking about, an increasing skeletal muscle index was linearly associated with decreased mortality. What they found was that a 1 unit increase, just a 1 unit increase in skeletal muscle index was associated with a 2% decrease in mortality. This is interesting because this is a modifiable factor. It's shown to be a modifiable factor, whether it's through nutrition, supplementation, and weight-bearing exercises. So it's interesting that they showed this linear effect in addition to the categorical effect seen for sarcopenia. In terms of muscle density and adiposity, there's been sort of a less clear picture in terms of outcomes and its effect on in kidney cancer. Intern et al. In a study published in Cancer looked at patients with metastatic kidney cancer, and they found that high skeletal muscle density, so this is a density we talked about in Hounsfield units, high skeletal muscle density was associated with greater survival in metastatic kidney cancer. Whereas Fukushima et al., in a study published in Journal of Urology, did not find a significant effect of skeletal muscle density on overall survival. So there's a mixed picture. You have some studies showing this protective effect of muscle density, other studies not showing a significant effect. Picture's even more unclear when it comes to adiposity. It's a paper by Steffens et al. Looking at patients with metastatic kidney cancer, where they found that higher adiposity was associated with greater survival. However, Zhu et al., in a study published in Journal of Urology, they found that higher visceral adipose tissue was associated with higher Furman grade. And then the same paper that we talked about above by Intern et al. Found no effect of adiposity at all on survival. And so with adiposity, we see a study showing a beneficial effect, a study showing a deleterious effect, and a study showing no effect. So really, we don't have a good understanding of what are the effects of density and adiposity and how they relate to survival in metastatic kidney cancer. There's a couple of interesting papers I want to go over. The recent papers that were very influential in the field of sarcopenia. There was a paper by Wen et al. Out of WashU that examined sex-specific effects and the relative percentage of adiposity in kidney cancer. So the reason this is important is because men typically have greater visceral adipose tissue, and premenopausal women typically have greater subcutaneous adipose tissue. And so what this paper wanted to look at was, okay, not necessarily the total area of adipose tissue, but what about the proportion of adipose tissue? How much visceral fat someone has as opposed to the rest of their adipose components, or how much subcutaneous fat someone has in comparison to their visceral fat. And they wanted to look at this in a sex-specific way. So what they found is there was no significant effect seen in men, but women with high relative visceral adipose tissue had increased mortality. So they found the sex-specific effect of the relative percentage of adiposity. There's another study by Cespedes, Feliciano et al., published in JAMA Oncology out of Kaiser Permanente. They looked at the relationship between inflammation and sarcopenia. So they looked at neutrophil lymphocyte ratio, sarcopenia, and survival in colorectal cancer. And what they found was that elevated pre-diagnosis neutrophil lymphocyte ratio was associated with at diagnosis sarcopenia. So sort of this connection between inflammation and sarcopenia. And they additionally found that patients who had both elevated NLR and sarcopenia had the worst survival. It almost doubled the mortality compared to patients who had neither. And then there was a paper by Kahn et al., also out of Kaiser Permanente, that was published in JAMA Oncology, that examined this sort of comprehensive body composition analysis. They looked at skeletal muscle index, muscle density, and adiposity in breast cancer. And what they found was that sarcopenia and greater adiposity were associated with higher overall mortality, but they found no significant effect for muscle density. So again, highlighting that we don't really have a good grasp of the effects of density and adiposity as well. But an interesting factor was that they found that patients with both sarcopenia and high adiposity had the greatest mortality. So what that sort of tells us is you have this one paper that shows that patients with high NLR and sarcopenia have the worst survival. You have another paper telling us that patients with sarcopenia and high adiposity have the worst survival. So it's interesting looking at these components, and what that sort of led me to think was, well, how can we combine all these components? Can we conduct a study that can look at all of these components? And so that's what the question I had was, do metastatic kidney cancer patients with, number one, sarcopenia, number two, low muscle density, number three, high adiposity, number four, high inflammation, all of these factors, do they have the worst survival? So that's what we sought to analyze using our kidney cancer database at Emory. We conducted a retrospective analysis of 165 patients with metastatic kidney cancer who underwent cytoreductive nephrectomy. Majority of our patients, we used CT, so it was about 70%. Preoperative neutrophil lymphocyte ratio was obtained within 90 days prior to surgery. And we also looked at the CT subset parameters. So we looked at skeletal muscle density, like we talked about, the average Hounsfield units. We looked at the total adipose areas for all the components, as well as the total adipose tissue that a patient had. We also looked at the relative percentage of adipose tissue, like we discussed from that Wen et al. Paper. And then there's two novel components that I personally just wanted to look at because I thought they would be interesting. Number one was the mean adipose tissue attenuation. So just as we looked at the muscle density, what about the attenuation of adipose tissue? With concepts such as inflammatory fat, the Mayo adhesive score, I thought it'd be really interesting to look at the mean attenuation of the visceral fat, whether this has any effect on survival. Another component I want to look at was an adipose tissue index. This is sort of a novel concept, but I was like, just as we created the skeletal muscle index, maybe we can look at the adipose index, getting the areas of the adipose tissue and putting it over the patient's height in meters squared. So those are all the components that we sort of added. And our focus, our main outcome was looking at overall survival. So what did we find? 47% of our patients were sarcopenic, which is in line with the numbers reported in the literature. Sarcopenic patients had, there was a significant difference in survival. They had median overall survival 11.4 months versus 19.5 months for non-sarcopenic patients. On multivariate analysis, patients with elevated neutrophil lymphocyte ratio and sarcopenia had the worst overall survival, 10.2 months. And this was an independent predictor of overall survival on multivariate analysis. Skeletal muscle density, interestingly, was not significant on multivariate analysis, but we did find a significant difference in terms of 1-year survival after cytoreductive nephrectomy. So 71% of patients with high density survived at the 1-year mark compared to 52% of patients with low muscle density. And interestingly, we did not find a significant effect on survival for all the adiposity parameters, whether that was the total area, the relative percentage, the mean attenuation, or the indices that we had calculated. When we studied these as an overall analysis, we didn't find an effect. And then when we stratified by sex, we still didn't find an effect. So again, didn't really help in terms of that unclear picture that we have for adiposity. So here are Kaplan Meier curves. You can see here the demonstrated effect of sarcopenia on survival, just the presence of sarcopenia. And here you can see the combined effect of elevated neutrophil lymphocyte ratio and sarcopenia. And so here you can see elevated neutrophil lymphocyte ratio and sarcopenia had the worst overall survival on Kaplan Meier analysis. So what were our limitations? It was a retrospective study. Our sample size, we had 165 patients. This is in line with other studies looking at metastatic kidney cancer, but we were limited by the amount of patients we had. Human error in segmentation. So that can contribute to error, although the intra-observer and inter-observer variability for slice-o-matic segmentation has been documented to be very low. So it's a very reproducible analysis that can be performed. And then the lack of further body composition analysis on MRI. So on MRI, we were only able to look at the skeletal muscle index. We weren't able to assess density or adiposity on MRI. So we were limited by that factor. And then the small amount of patients that we had that had a low NLR, but were still sarcopenic. You can see we didn't have too many patients. We were limited by that in our analysis. So what are the future directions we want to take this research? Number one is body composition on MRI. So being able to get these additional components on MRI, getting muscle density and adipose tissue, because that's kind of the severe limitation is we're not able to assess this on MRI. Dixon sequence, so this is a sequence on MRI that can tease out fat and water. It's great for segmentation. Unfortunately, we did not have that sequence on any of our patients, but we're now prospectively ordering this sequence on all of our future kidney cancer patients so that we can do this analysis, because I think it would be interesting, particularly with the concern for radiation exposure. I think it's important to have this sort of analysis on MRI. Automated segmentation. So I'd experimented with an automated module for slice-o-matic where you just click a button and it segments in roughly 2 to 3 minutes. But it was terrible. I mean, you had to have perfect CT or MRI slices and the quality can vary. And so it wasn't ideal. But I think the concept of developing an automated module that can, with just a click of a button, segment CT and MRI would be great because we have this imaging available for our patients. And so I think if someone was able to develop this concept, I think it would be very useful. And also looking at non-metastatic kidney cancer recurrence. That's something we're currently analyzing right now. And then immune parameters and sarcopenia. So I had done research with flow cytometry looking at tumor-infiltrating lymphocytes in kidney cancer. And our preliminary data showed that the total percent CD8 tumor-infiltrating lymphocytes was associated with recurrence and survival. So the lower infiltration that a patient had was greater recurrence and worse survival. And so I want to tie that into sarcopenia because I think that would be very interesting. How does this relate? Because there's this relationship between inflammation, immunology, and sarcopenia. And it's sort of this chicken and the egg relationship. And I think that, with the advent of immunotherapy, it'd be very interesting to see if sarcopenia is a potential component that can lead to, prognostication or risk stratification for immunotherapy. So I think that's the really interesting avenue that I want to take this research. We're currently performing that research now. And so in conclusion, sarcopenia via skeletal muscle index provides an objective patient-specific parameter that can be measured on available cross-sectional imaging. We have this imaging and we're able to get this as a more objective parameter as opposed to subjective performance status measurements. And I think that not only is it an objective parameter, but it's also a modifiable parameter, whether it's through nutrition or through weight-bearing exercise. So I think that's an important component. Metastatic kidney cancer patients with preoperative sarcopenia and high inflammation have the worst overall survival. Low preoperative muscle density is associated with decreased one-year survival. And further analysis is needed to assess the effect of adiposity, because we really have an unclear understanding of how that contributes to outcomes in malignancy and specifically kidney cancer. So with that, I'd like to thank Dr. Shulam, Dr. Hiddleman, Ms. Christine Miranda, Ms. Lucia De Matteo, all the faculty, residents, and staff for what's been an incredible and unforgettable month. It's a privilege to be here, so I really appreciate being given the opportunity. Thank you very much.
Given the fact that the total longevity of this entire population is relatively short, it doesn't allow interventional strategies to correct some of this because of the time limitations. I'm just wondering if you've been able to translate some of this data into either preoperative or immediate post-op ancillary support for these people, either nutritional intervention or other parameters, other things.
Yeah, we haven't done that, but I think that would be interesting to look at. There was a study by Fukushima that looked at the kinetics of skeletal muscle index and how that changes post-operatively. But I think, yeah, that would be an interesting thing to look at, especially outside of even metastatic kidney cancer and other urologic malignancies, to see how, how this can change with interventions in terms of exercising and how that can affect post-operative outcomes.
So I was wondering, I would imagine there are different reasons for people being sarcopenic prior to surgery. And I would imagine there are some people who are baseline sarcopenic, and there are some people who might be sarcopenic related to weight loss due to their malignancy. And I was wondering if you'd looked at that at all, and if when you did your multivariate analysis, if you looked at either performance status or preoperative weight loss, and to see if, does this add something other than asking them about weight loss and their performance status in the pre-op setting? So
we looked at ECOG performance status and Karnofsky, and we didn't find a significant effect in terms of sarcopenia was not related to either of those, and they were not significant on multivariate analysis. We didn't look at weight loss specifically, but there was a paper by Martin et al. That did show that 5% weight loss or even greater than that had this effect on survival. So I think that's interesting. We weren't able to capture that data point. But in terms of the performance status, it was independent. And then another thing that a lot of people mention is albumin. Albumin was not significant for us as well. We didn't find it significant on univariate or multivariate, and there's no association between sarcopenia and albumin in our study, and in Suk et al. And Sharma et al. So it shows that sarcopenia can exist even in the presence of normal albumin levels. So I think that it's a more robust marker of nutritional status. But yeah, that's interesting.
And kind of an unrelated question, but somewhat related to renal surgery. So, obviously serum creatinine is dependent on, on body composition and muscle mass. And has anyone looked at using these more objective measures of lean body mass as a way of improving serum creatinine's ability to estimate GFR?
No, they have not looked at that. I know Suk et al. In our paper, we included eGFR, estimated GFR, in our analysis. We didn't find any association with estimated GFR. But no, that would be an interesting avenue, I think, for future research.
One of your non-medical friends from college asked you, how do most people with cancer die?
Most people with cancer die.
Stroke, heart attack, are they wasting away?
I would imagine wasting away.
Unlike popular TV, where there's a significant event like a or something, most people die from end organ failure from wasting away, right? So I wonder if this is just really a measure of where on the scale of their cancer death they are.
I don't know. I think, I think that it's been shown independent of a lot of other factors on multivariate analysis that have been associated with survival. And I think that, it was a pretty robust effect that we observed and in additional studies. I just think we need more studies, and we need to have larger studies to look at it, but it's possible. It's possible. Yeah. No, I agree. And I think highlighting the point that had been previously mentioned, I think we need to have some studies looking at the modifiability in the context of cancer. Because I think I agree. But I think that it has a useful ability in terms of identifying these patients who have reserve and don't have reserve. How do we identify those? I think that this is a better way to identify compared to albumin, compared to performance status. I think that's been shown in the literature. So it's like, how do you identify the patients who have worse reserve and who have better reserve? I think in terms of causality, yes, that's a little more difficult, and we need to study that more to see, what the picture is.
It's interesting that this is sort of dovetailing with Dr. Straub's comment, but is this a modifiable risk factor, and is it just nutrition? So I got called about a company that actually it was started by urologists, GTX, and they have a drug that is against sarcopenia. It's a androgen receptor modulator. And they gave this for women with stress incontinence to help build up striated muscle in the pelvic floor, and they got a signal of reducing stress incontinence. So there are other ways to potentially modify sarcopenia without obviously just nutrition. I was just Googling besides, it's called enobarsarm or something like that by GTX. But they actually have an FDA label indication for sarcopenia from cancer to reduce sarcopenia. It's not going to be survival. I think it's going to be quality of life type of issues related to sarcopenia. But there's already pipeline agents that you can think about, besides looking at risk factor. I mean, is it a modifiable risk factor is probably the most important question when you go in looking at it, because we can't change anything,
Yeah.
Great talk. It's a nice way to use another marker to look at these kind of questions that have been asked a long time. And so, congratulations for that. A couple questions. One, has anyone looked at SMI and anergy? If you can, you say they lose their immunologic response receptivity. If you lay PPT on these people and they recover, does that get better? Another question I have also is, using this adipose density, has anyone looked at LR ratios and like toxic fat? There's this, we all know about this. Some kidneys are easier to resect than others, and men have more of this toxic fat than women. Any of these markers that you looked at can help predict that?
So no, in terms of the first, I have not seen that in the literature, but I think that's very interesting. I think in terms of the inflammatory fat and this toxic fat concept, no, I think this is the first study to look at the attenuation of the visceral adipose tissue. There's no other study that's looked at mean attenuation. So I think it's an interesting avenue, in terms of surgical outcomes as well. How does this relate to, I know they did it with the Mayo adhesive score, but visceral fat has sort of been evolving as this hormonal component of our body. So I think that's very interesting. There hasn't been much research on it, but I think the opportunities are endless in terms of what we can assess in terms of adipose tissue.
Sure. I had a quick question as well. I think you mentioned quickly, but I didn't catch it. So why can't we use MRI similarly to measure sarcopenia or like an equivalent sort of marker?
Yeah. The reason why, so MRI, we use T2 weighted MRI, but the reason why MRI is difficult is because on CT, you can use these defined Hounsfield unit thresholds. With MRI, there's so much variability in the gray values that you have to individually do it for each MRI. MRI, really, no one had done it on mid-L3. I published another study just on the methodology of how to do segmentation on MRI, because this is a very kind of new direction. But it's difficult because you need to look at each MRI individually and look at the thresholds of the gray values and find how you can segment the muscle. And so that just takes a lot more finesse. It's more difficult. And so that's sort of why MRI has been limited. But if we get the Dixon sequence, it's much easier to see the peaks in the different tissues. So that's what we.
Because my follow-up question to that is that we get obviously a lot of imaging on patients with kidney cancer, also patients with staging for bladder cancer, prostate cancer if they're high risk. But what we do a lot of these days is we get MRIs on, I think, depends on the surgeon, but virtually everyone going in for robotic prostatectomy. And speaking to Dr. Chai's point, I was wondering if anyone's looked at in those areas. So no, you're not as high as L3. Looking at pelvic floor musculature, looking at, is there a way of finding a marker at that level for overall sarcopenia, and or a marker of pelvic floor strength, or maybe postoperative stress urinary incontinence, et cetera. I think there's a lot of data on things like elevated BMI leads to higher rates of stress incontinence, et cetera. But obviously that's BMI. I'm just wondering if there's, if you've seen anything to do with that. Otherwise, dibs.
Yeah, no, I haven't seen it. There's been studies with bladder cancer, lung cancer, GI cancer, but I haven't seen prostate cancer. I think that's really interesting. I mean, yeah, it would be great to look at it in terms of, pelvic floor, looking at different levels and seeing how that would relate. So it's a good avenue to look at.
Yeah, there's a lot of data out there.
So I reviewed a grant a year or two ago through the Augs Foundation looking at sarcopenia and female pelvic floor surgery outcomes. And I had to look up the term because I had not heard of it and I wasn't quite sure what it meant. So I think it's also, as even in benign surgeries, we're increasingly operating on older people. So it is something that's being looked at, I think, as a measure of frailty, like kind of just to go into that whole thing, because not all 70-year-olds are the same. And I just did a quick Google search. And so, part of it, kind of like, I think this is similar to personalizing pelvic floor reconstructive surgery in aging women, association between muscle loss and urinary incontinence in elderly women, and then exploring the role of functional impairment in sarcopenia and the non-surgical treatment of incontinence. So there's definitely people looking at it. There's not a ton of data on it, but I'm pretty sure probably some of these studies are using sarcopenia to look at pelvic floor musculature. So it would be probably relevant, to pelvic surgery outcome in general, in terms of functional outcomes also possibly.
All right, thank you so much.
All right, that's good. So I'm going to present an interesting case. There are some good pictures in this. Unfortunately, as you know, we've changed from Synapse to a new methodology, and so the only picture I got, I had to take a picture with my cell phone, and that became a little troublesome. So we'll just talk. If you could teach how to do it properly. Yeah. If there's a new way of doing it, I'm sorry, it's still a little new. I appreciate it. So I'll be talking about an interesting case today that we saw, I think about a month and a half ago. So this is a 14-year-old African-American female who presented to the hospital because she was brought into by the police after running away from her home. And she said she had persistent suicidal ideation, and that's why she presented. At the time when she came in, her blood pressure was 160/100. Her heart rate was 89. Her only medical history is notable for type 2 diabetes. She had some lab work done, which showed some mild anemia, but her creatinine was normal. No other significant findings. On further discussion, she endorsed that she gets feelings of dizziness and palpitations with urination, sometimes so severe that she has to lie down. She was then referred for a renal ultrasound to look for renal artery stenosis, and they also took a picture of her bladder at the time. It's my cell phone. Here you can see that she had a large hypervascular mass in her bladder concerning for malignant etiology, with the thought of this being possibly a rhabdomyosarcoma versus a paraganglioma. She then underwent an MRI of the abdomen and pelvis with and without contrast, which again reconfirmed that she had this approximately 5-centimeter solid mass. She also had multiple left-sided internal iliac lymph nodes up to 1.8 centimeters in size. She subsequently underwent a PET-CT dositate scan, which showed an intensely avid bladder mass, metastatic pelvic adenopathy, possibly upper abdominal adenopathy, and multiple bony metastases, which are most compatible with a neuroendocrine tumor from the bladder. I won't show you more images. Her lab work returned. It was notable for her urinary 24-hour metanephrines, had her norepinephrine was over 12,000. Normal is less than about 300. And her metanephrines were, again, over close to 13,000, less than 400. She had genetic analysis performed, which showed that she had a succinate dehydrogenase B missense mutation. Medically, she had an interesting course. Her blood pressure was optimized on doxazosin and metoprolol, and she was discharged to the outpatient management. A month later, she was seen in the pediatric oncology clinic, and her blood pressure at the time was 194/105. So she was admitted to the pediatric ICU for management of her blood pressure and sent home the next day. Her plan at that point in time, after discovering this metastatic disease, is that she was going to undergo 2 cycles of cyclophosphamide, norepinephrine and dacarbazine, with a reevaluation after that point for possible resection of her primary bladder tumor. She did undergo a port placement, which was done by the pediatric surgery team. During the procedure, she became BP became extremely volatile, blood pressure ranging from 50/20 to 250/160. In fact, even higher was thought. At one point, they thought the diastolic was 210. She was admitted to the pediatric ICU, intubated and sedated. We were consulted for concern that any catheterization could possibly stir up more catecholamine release. And so we placed a very small catheter. We did not inflate the balloon with the thought that there would be limited risk of pulling on the mass and releasing things. She subsequently did well. She actually had her blood pressure control within a few days. She now has been discharged, and she has just recently finished her second cycle of chemotherapy. So we'll be discussing more about her later. So I want to talk a little bit about pediatric paragangliomas. We've had, this is probably, I think, our second patient of this in the last couple of years. So these arise from chromophant tissue from the sympathetic innervations of the urinary bladder. This is specifically, sorry, for a paraganglioma of the bladder, obviously. It's very rare. It's 0.06% of all bladder tumors, and about 6% of all paragangliomas present in the bladder. If they are hormonally active, as our patient was, then they can cause symptoms of catecholamine excess, hypertensive crises, or this post-micturition syncopal events, which is exactly what this patient described. Very interesting. About 17% of tumors are not hormonally active. The last patient we had with this was not hormonally active. And about 20% of these tumors have malignant behavior and they metastasize. If they are isolated in the bladder, they're usually managed with a partial cystectomy after appropriate preoperative assessments and optimization to prevent the sort of intraoperative crises that she had with her port placement. And it's usually, and it's similar to resection of adrenal pheochromocytoma when it comes to the preoperative management. The youngest reported case is around 7 years old. Our patient was 14. So I'm talking about succinase dehydrogenase B genetics. So this is one of the enzymes which catalyze the oxidation of succinate to fumarate in the citric acid cycle. It acts as a tumor suppressor gene. It's kind of unclear why it specifically causes problems in paraganglionic cells, but it's just been noted to do so with any loss of heterozygosity. And depending on which subunit is mutated, you get a kind of a different familial paraganglioma syndrome. So for the patients like our patient here who had SDHB mutations, it's a type 4, which increased the risk of extradenal paragangliomas and with a very high rate of malignancy and metastasis, as we saw in this patient. So I want to talk a little bit about, just very quickly about that dotatate scan, which is something that I had not heard of before. This is a type of PET-CT scan used to localize specifically to metabolically active pheochromocytomas and paragangliomas. Here is just this is just kind of a picture of a review of multiple different PET-CT scans that they use for paragangliomas. The one on the left, A, is was the dotatate scan, and it was able to identify, you see via these arrows, kind of multiple lesions which were not identified on other previously used PET-CT scans for metastatic pheo. Most notably, I think kind of the classic test question answer for what scan do we use for metastatic pheo is an MIBG scan, and that scan is actually so outdated and so bad they didn't even actually show a picture of it because it didn't catch any of these lesions. So MIBG is no longer kind of standard of care when it comes to metastatic pheo. Oh, sorry. I don't know how to lift it up. Can you hear me now? I'll speak louder. Sorry. And then just kind of briefly talk about malignant pheochromocytoma. How is it managed? So when it is identified, you obtain a cross-sectional imaging to evaluate for metastatic disease. If it seems to be resectable, then we usually try and perform a resection. studies have shown that patients who have mostly or only visceral intra-abdominal metastasis do better than patients who have extra-abdominal metastatic disease. For example, our patient, so she had, again, diffuse bony lesions, especially in her clavicle and her skull. If you have unresectable disease, there are multiple different options available. There are targeted radiotherapies that are tagged to specific markers, which hope to kill the extraadrenal tissue. If there's more symptomatic localized therapy, you can do external beam radiation therapy. And then for patients like ours, who have the widely metastatic disease and kind of the worst concern, then you can perform chemotherapy. And so that's what she has now. Any questions?
So was there any disease in the adrenal gland?
No.
It was all pure extraadrenal.
Purely extraadrenal. So adrenal gland was clear. So she had a very large bladder mass, as we said, the positive lymph nodes in her left pelvis. She had her right clavicle and her upper jaw had large lesions at the base of her skull, and multiple others kind of scattered smaller lesions. I think this case was very interesting, though, because she kind of presented with a very classic post-micturition symptoms, when prompted, and of course actually had a true hypertensive crisis during a port placement. So I'm not sure whether that has something to do with, I'm not sure which side they put the port on, but something to do maybe with the clavicle. I'm not sure how it's necessarily stirred up. Well, that's another thing. I mean, a patient who has, I don't know, but I thought about that myself too. A 14-year-old girl who's having extreme catecholamine release, maybe her emotional state was jeopardized. But I don't know. I think she had quite a troublesome social history at home. So she had other issues certainly beyond just hormone imbalance. Yeah.
Not during my boards, but during someone's boards, this was an actual question.
Mm-hmm.
Oral boards, on that pathway you have surgical resection.
Mm-hmm.
On that pathway to resect the tumor, what do you do to prepare for surgery?
So the classic answer is you use alpha blockade. Well, back in the day, we used to admit them preoperatively for significant IV hydration plus alpha blockade. I think it's a phenoxybenzamine. I think is the irreversible alpha blocker, and you monitor their blood pressure status. So by reducing the kind of that chronic alpha, agonism from the catecholamines, their blood pressure drops. So that's why you give them more fluids to keep up their blood pressure. But sometimes you also get you also get kind of off-target beta agonists, and so you have to use secondary treatments as well to continue to keep the blood pressure low. And I think you use metirazine is what I remember off the top of my head. That's kind of the classic answer is admission, IV hydration, alpha blockade.
As the operating room, would you lower their blood pressure? They have a spike 100.
I think you use something like clonidine, something like an alpha blocker. No.
Very quick.
As
Like,
nitroprusside.
So these people, they all have like significant alpha agonism,
Mm-hmm.
kind of, that you said, and then so they're all relatively volume treated.
Because things are tight.
And so the idea of we used to admit them is because I've always got to correct that volume problem. But if you block them orally, phenoxybenzamine, or even oxazocin, but if you block them with an oral agent ahead of time, as long as they have intact thirst and access to water, you don't need them ahead of time for hydration. So you block them ahead of time and their volume status will come back on the phone. That's why these people have such profound hypertension, because they have no control, right? So if you treat alpha agonism and they haven't been blocked ahead of time, all of a sudden they have no zero preload cardiac output plummets and blood pressure.
Is the brain.
cold state is gone. But resected and they no longer have their catecholamines swing around, so they lose the vascular squeeze without the hydration status to
Yeah, it was just interesting in this patient because obviously, at that point in time, they knew it was a paraganglioma, was metabolically active, and still, even with preparation on the doxazosin, et cetera, she still had this, this terrible issue with her pore placement. So, definitely shows it's concerning. Yeah.
That's one of the potential advantages of that is that doxazosin is non-competitive, right? So you can give them all the same as giving them phenylephrine, right? Give them all the phenylephrine in the world, the blood pressure is not competitive. But doxazosin is competitive. So you have a huge load that you can overcome it. So perhaps she would not have had that responsibility.
Probably, I can't speak to it, but I mean, it was 12. Her medinephrines were 12,000. And if you look at the literature when they're talking about, sussing out whether things are paragangliomas, I mean, a lot of these metabolically active paragangliomas, the numbers that come out, if you remember, the normals like under 300 for the norepinephrines under 300. Like they're talking about, like a lot of these patients who are metabolically active come in with a norepinephrine of like 500, 600, not 12,000. So as you said, maybe she wasn't the great candidate for the doxazosin and should have been on something else. But again, I'm not an endocrinologist. I don't want to pretend to be. I think it depends. I think a lot of patients don't have like alpha agonism as the etiology of their hypertension. Yeah. No. Really? No. Did they use it back in the day as like as a standard blood pressure med? Yeah. I said irreversible earlier. That was that's yeah. Yeah. It's on. All right. Thanks very much.